COVID-19 is not your normal virus, and there is so much we still do not understand about this disease. Over the coming weeks and months, a lot of what we say today will change. There are some things that we do know. The majority of patients who develop this infection will not become unwell. They may get minor symptoms or no symptoms, persistent cough, a high temperature, maybe some breathlessness, maybe some taste changes, nothing more than that. And then there's that group who become extremely unwell. They present with low oxygen tensions in their bloodstream, and in the early phase, they present what we call the type L phenotype, as described by Gattanini in a recent editorial. This type L phenotype is typified by the low oxygen tensions in the bloodstream, but little in the way of respiratory decompensation. Good lung compliance, the patients may not even look overly breathless given their low oxygen tensions. Their CT scans may demonstrate some ground glass appearance, and the best treatment for these patients seems to be non-invasive ventilation or CPAP or simply nasal oxygen, because invasive ventilation may actually be harmful in these patients unless they get really tired. In the type H, what we see is a typical ARDS picture. The lungs fill with fluid, and these patients need invasive ventilation and PEEP, high pressure ventilation, because the lungs have lost their compliance. Radiologically, we see the typical florid whiteout of ARDS. Now, the reason for presenting this in a talk about pharmacology is to go back to the type L patients. What is going on in those patients that gives them such a low oxygen tension with little in the way of respiratory decompensation? Very similar to the sort of thing that you might see in malaria infection or perhaps in high altitude sickness. This is what is creating some intrigue. The concept that what we're seeing in these patients is an oxidative stress. And it is this oxidative stress that leads scientists and physicians to suggest that certain drugs may be really useful in this part of the disease process. The use of antioxidants such as high-dose intravenous vitamin C, the use of glutathione, the use of inhaled hydrogen, and of course the use of hydroxychloroquine, the type of treatment that we use in malaria. We don't know that these drugs will work, but there seems to be some anecdotal evidence that in some groups there seems to be of benefit in using these drugs. Now, of course, the types of drugs you might expect people want to look at in viral infection are antivirals. And we do know a lot about antivirals in the treatment of MERS, in the treatment of HIV. And there are two main trials that I would like you to keep an eye on over the coming weeks and months. Those are the Solidarity trial, driven by WHO, and of course the Recovery trial, driven by the NHS in the United Kingdom. These trials are designed to look at the efficacy of simple supportive treatment or simple supportive treatment plus a drug of choice. And the trials will be using different drugs. Both will be using hydroxychloroquine in one of the groups. Both will be using the typical antiviral HIV treatment strategy, which is lopinavir plus ritonavir. In the Solidarity trial, they will also be combining that HIV combination with beta interferon. And the fourth drug that they will be looking at in the Solidarity trial is remdesivir. In the Recovery trial in the United Kingdom, one of the groups will be looking at the efficacy of low-dose steroids, dexamethasone, an antibiotic, azithromycin, and also an anti-inflammatory drug called tocilizumab. So I'm sure the drugs that they use in these trials will change over time, but it'll be interesting to see what this data demonstrates. For now, most of the drug therapies that we use in the clinical setting are really driven around supportive in nature. If a patient gets a secondary respiratory tract infection, we treat with antibiotics, for example. If the patient needs hemodynamic support, we will use the same hemodynamic medications that we might use to support the patient. In the early part of the disease, often we see vasoconstriction as a result of angiotensin II. Later on during the crash phase, one may need to tighten up the circulation with drugs such as noradrenaline. So it's really on a day-by-day basis based upon invasive measurement of the patient's hemodynamic state and the respiratory state that leads us to decide what treatment strategy we need to provide.